So, Dr. Naresh Yadav would now be talking about OCT angiography in common retinal macular diseases.
I'll be speaking on OCT angiography, what all can it show. So basically we know that FFA ICG is the gold standard to visualize and study the retinal and choroidal vasculature, but it has some side effects, and OCTA is the newest tool which gives us equally good information, and it is dye-less, it is quick, has no side effects, and it's repeatable. So basically at each and every visit you can do OCTA. And the other advantage is it gives a 3D, sort of it segments the vasculature. So you can study about the individual vasculature in detail. So the principle is very simple. Basically, if there is a static tissue and if you do repeated OCT scans, all scans are going to look exactly the same. But if the tissue has blood vessels and the RBCs are moving in that, so this will cause a change in the reflectance signal, and this change is known as decorrelation signal. And this OptoView that we have, it uses one algorithm that splits the OCT signal into 4 or more narrower bands, and then you get an average decorrelation, and each narrow spectral band gives independent information on the flow. Sorry. So basically, this is the way the vasculature is segmented. So you get 4 layers. One is the superficial capillary plexus, deep capillary plexus, outer retina, and the choroid capillary. Outer retina usually does not have any vasculature. Any vasculature seen there is abnormal. And this is how the printout looks. So you get the 4 slabs, and the OCT also is co-registered. It is besides there. So you can really get a good correlation of the level of the vasculature and what the pathology is there. So it gives both OCT and FFA like features are both seen. So now I'll go to the uses. Very simple uses I will just tabulate. So you can look at the microaneurysms. So basically FFA is still the gold standard, but OCTA also can pick up to 40 to 50% of the microaneurysms. And the prognostic value is that if you see more microaneurysms in the deep capillary plexus, such patients could have more cystoid type of edema, and these patients could be poor responders also. So OCTA can give you some value regarding the prognosis. The other is, if you look at the FAZ, in the down slides you can see, so the larger the FAZ, the patient is not going to respond very well. The other markers also are there. You can look at the circularity of the FAZ, and larger FAZ could correspond to the drill also. And the other is in the deep capillary plexus, you can see here there's a area of non-perfusion. So such areas usually correspond to the disrupted outer plexiform layer. So if you see the disruption there, these patients also may not do very well with the anti-VEGF injections. The other is, it's very good to pick up new vessels. Sometimes there is always a confusion whether it's a IRMA or a NVE. So OCTA picks up the neovascularization in a very good way, and then it's very good for follow-up also. So you can see here, there's a large exuberant vascular proliferation, small capillaries, and post-laser, it has sort of come down. Similarly, in AMD also, various patterns are recognized. There's a C-fan pattern. It sort of radiates from one side of the lesion, and there's a Medusa pattern. The vessels branch in all directions from the center of the lesion. And here there's no distinct morphology of the membrane, but you see a small capillaries, and this is dead tree trunk pattern. So all these patterns can be picked up on the OCTA. So basically this is one of our patients. You can see there's a classic CNVM. The OCT shows subretinal fluid with pocket of IRF, and this is the CNVM complex that you see. Could I get this? Sorry for. So you can see how nice the octa shows the C-fan pattern of the vasculature, and this is post anti-VEGF. So you can see the vasculature has come down, the small vessels are less seen, and the OCT also shows there's no edema, and you see a sort of scarring happening. The other useful is in the octa, in PCV. So for BVN it is very good. Almost 85 to 100% of the BVNs can be picked on octa. But polyps sometimes may not be picked up. So that could be because of the less flow, or it could be extramacular in location, or the segmentation is not proper. Because sometimes the polyps could be at the base or at the apex of the PD. If the segmentation is not going through that, you may miss the polyps. This is one of our patients. You can see there's a subretinal polyp here. The ICG shows a bunch of polyps here, and one polyp is seen hyperflow, and this is a hyperflow. So hyperflow polyps are likely to better respond to treatment. So in myopic CNVM also it's very important. 5 to 10% of the patients with pathological myopia can lose vision because of myopic CNVM. And the subretinal heme that you see, it could be because of a new lacquer crack. There could be no CNVM. In that case, injection is not required. Or it could be because of a CNVM formation that you see here. So every time you cannot do FFA. So you can do octa. So here you can see the CNVM complex, and the CFT is increased, and the octa picks up the myopic CNVM in a very good way. So octa is very useful for myopic CNVMs. And when to stop the treatment, that also it can give an idea. So this is the same patient, this is the pre-injection, this is post-injection. You can see the vasculature has come down, and this also some improvement is there. And the patient had a recurrence. So this time FFA was not done. The octa itself shows the pattern of the vasculature has changed, and this is the corresponding OCT. And the other important is patients with chronic CSCR who don't respond, and the fluid remains there for up to 4 to 6 months, and there's a flat irregular PD that is known as FIPED. Such patients also could harbor neovascularization, that is known as pachyneovasculopathy. So the FFA may not give much information, it just shows a hyperfluorescence. But if you do octa, you can see a vasculature here, neovascularization. So such patients respond well to anti-VEGF. So any patient with chronic CSR who has a flat irregular PD, you should rule out neovascularization, and octa is very useful. For type 1 sub-RP membranes, octa is very useful. So another use is in MACTEL. So basically in MACTEL, you can see there are just some, if you do FFA, it shows temporal hyperfluorescence, telangiectatic vessels, and if there is a CNVM, sometimes picking up it becomes difficult because there is a hyperfluorescence that the capillaries themselves are leaking. So you cannot make out whether it's leaking from the CNVM. So this is octa. So you just see how much the information you get through the octa. You can see there's a enlarged FAZ, there is a pruning of the vessels, a rarefaction of the vessels. So all these features you cannot really appreciate on FFA. So octa has given us a lot of clue about the pathophysiology of MACTEL. The disease usually starts in the deep plexus, and then it goes to the superficial plexus. So it has been very useful. So this patient, you can see in both the eyes there is a neovascularization. So this patient will need anti-VEGFs. Similarly, this is the last case, hypertensive choroidopathy. So whenever there is a accelerated hypertension, it can cause changes in the retina, the choroid, and optic neuropathy also. So, and doing FFA in such cases is difficult because already there is a uncontrolled hypertension. So if you do octa, and this is the corresponding OCT. So because of the choroidal ischemia, it's going to damage the RP, and then you can get hyperreflective material in the subretinal space, So this is all features of hypertensive coronopathy, and you can see the octa also, how nicely it is showing the flow void areas. So it gives a systemic clue. So because this is going to translate in all the organs, so whatever the microvascular changes are happening in the body can be appreciated by octa. And this is a case of CRAO. Our case, you can see there's a sparing of the ciliaretinal artery, and this is the FFA, and we did paracentesis, and then immediately we did octa. So you can see the change that has happened. So you cannot really do FFA after paracentesis. So basically, to conclude, octa images the retina and the choroidal vasculature in a dye-less manner, but the disadvantages are that a small area is imaged and is difficult in patients with poor vision, learning cost, and availability is an issue. But now we have new machines which give a broader area, larger area, and new machines, prototypes have given us flow speeds also. So it will image the flow also. So you will get a fair idea about now it just tells whether there is a RBCs are there or not, but it does not tell about the flow. So the higher flow could be the arteries and lower could be in the veins. So all these things are coming up. So thanks for a patient hearing.